Okay, so thank you very much for the introduction. My name is Marzia Cescon, and I'm going to present a joint work with Lea Prade, who's here in the audience. So before we dive into it, I would like to spend a few introductory words. So in my lab, the Advanced Learning, Artificial Intelligence, and Control, we are interested in personalized healthcare, okay, regardless of the disease. And in particular, we ask ourselves, can we use data that we can collect either from patients or in silico from a digital twin of the patient to optimize intervention for that particular individual? And we are currently investigating the application of Bayesian optimization to solve this problem. And I'm going to show you how we're going to do it for type 1 diabetes. So these are my disclosures. Yes. Let's see how the healthy glucose regulation works in the body. So immediately after a food intake or a stressful situation, glucose concentration rises in the bloodstream. And this triggers insulin secretion by the pancreatic beta cells, which in turn bind to the insulin receptors here in the cell. You had the animation starting ahead before. And this lets glucose get transported into the cell for utilization immediately or for storage in the liver and in the muscle cells. Now, glucose uptake acts as a brake pedal in a car, let's say, lowering glucose concentration to a healthy level. Now, in between meals, during resting, or in case of physical exercise, the pancreas releases glucagon, which is a counter-regulatory hormone to insulin. And glucagon goes into the liver, breaks down the previously stored glycogen molecules to release back sugar again in the portal circulation, like the speed pedal in the car, so that we have a healthy glucose regulation again. So the body uses these two manipulative variables, these actions, to achieve a rather tight glucose control, like you see here in this image. Blood glucose in milligrams per deciliter in the y-axis and hours in the x-axis. Now, when glucose metabolism is impaired, the patient develops diabetes. And in particular with type 1, the regulatory path and the secretion of insulin is totally broken. So patients with type 1, they need to inject insulin exogenously for survival. So their therapy looks something like the following. They have to measure glucose concentration with some sensors, either with a finger stick or a continuous glucose monitor. They need to inject insulin exogenously with certain devices. And why do they do that? Well, because they want to counteract, they want to reject what we call disturbances. So glucose fluctuations due to meals, exercise, and stress. So what is the objective of the therapy? Well, how much sugar you want to have in the blood. So if we have half a packet of sugar, this is considered hypoglycemia, so this is no good, too little glucose. 1 packet of sugar between 90 and 100 milligrams per deciliter is okay, it's all we target. And 2 packets of sugar, it's hyperglycemia, so too much. So patients monitor their glucose, inject insulin to reject disturbances to achieve 1 packet of sugar in the bloodstream as regulation. Now, automatic control principles can be used to close the loop, like we call it, on the patient that is sitting here, so that we can achieve automated insulin delivery and therefore better treatment outcomes. So what are the ingredients? Well, we have the sensor here. I showed you the sensors before. We have the actuation here, so some devices that deliver insulin. Now, in conventional therapy, the patient has to make the decision. So the calculation regarding the doses and the management of the treatment is up to the patient. But if we close the loop, we are going to have a decision algorithm implemented either in a smartphone, like we have in this cartoon, or even embedded in a chip on a board in one of the devices that the patient has, okay? And the decision algorithm, as I told you earlier, has to reject these disturbances, again, meal, exercise, stress, illnesses, hormonal fluctuation due to menstrual period, and so on and so forth, to to achieve the goal of 1 packet of sugar in the bloodstream. And here we close the loop, okay? So in my lab, we are concerned with the design of this block here, the decision algorithm. And in particular, we focus on what we call continuous subcutaneous insulin delivery of insulin, which is depicted in the cartoon here on the left. So we have the patient sitting here. The patient is taking insulin subcutaneously, so in the subcutaneous tissue, infused in the subcutaneous tissue, with feedback measurements every 5 minutes taken by a continuous glucose monitor. And on the right, we have the cartoon represented the glucose curve, the fluctuations on the top. You can see the rise due to breakfast, lunch, and dinner. These are simulated data, just a representation. And on the bottom, you have the insulin doses. So we have a basal rate to maintain homeostasis at rest, and then some superimposed doses for the meals and corrections, so that we can achieve the same tight control that we showed before. So in my lab, we have developed an algorithm that we call data-enabled multi-step predictive control. I'm not going to go too much into the details. I just point the major steps of this algorithm. Step number 1 is the identification of an individual-specific blood glucose predictors based on data. The number 2 step is the tuning and the adaptation of the aggressiveness of the insulin delivery, again based on data, using a digital twin of the patient. And then the 3rd step is the solution of an optimal control problem. So what I'm going to talk about today is how we perform this tuning with Bayesian optimization, as I have introduced at the beginning. So if we add some formalism to the cartoon I showed you earlier, the patient is still sitting here. So the measurements from the sensor, we call them output, and we call them Y of t. The inputs to the patient are the injections, U of t. We get the measurements from the patient, and we feed them back to our machinery, the decision algorithm, so that we achieve 1 packet of sugar as a set point. So we're merely concerned with this block here. And how does it look like? Not too many formulas today, but some I have to show you. So we have to solve a finite horizon optimal control problem that we have here at the top. So we want to minimize some cost function, okay, that is related to the objective of achieving 1 packet of sugar in the bloodstream. And this is subject to a prediction model and certain constraints related to the maximum and minimum glucose concentration that we have in the body, and also a maximum and minimum actuation, because we cannot deliver infinite amount of drug. And here in the bottom right, you see in this cartoon how model predictive control works. So we have our prediction model in blue that is telling us how glucose is going to evolve in the future, depending on how much insulin you take and any other factor. The goal is to reach this target reference, the dashed line. Now, the optimal control problem solves for this U star variable, which is here represented in red. So it's going to give you the trajectory over a certain future horizon, capital T, so that your desired reference is achieved. So your blood glucose is going to be in that range. We applied the first step of this control action, and we move the horizon forward. And we repeat the same optimal control problem for the next step. So now, since we know that the glucose metabolism is highly individual, there are variabilities, we can personalize this machinery at several levels. So we can have personalization in the prediction model, we have personalization in the constraints, but what we're going to do now is to look at the personalization in the cost function, okay? So let's take a closer look to the cost function. We have a term here which is penalizing the deviation of my prediction, y hat, from the reference, from the set point, y bar, through a parameter q. And then we also penalize the control input, so the difference of the next input from some basal, let's say, through a variable r, okay? So by tuning these two parameters, we can have control of how aggressive and how loose, let's say, we are in the insulin delivery. Now, if we test the combination of controller parameters, this is going to be very expensive. We have to run multiple closed-loop control experiments, even if we have a digital twin. So what we do, we find a function that we call f of x, right, that is related to the therapeutic benefit of our strategy. In our case, for instance, we can postulate the percent in time in the acceptable glucose range, say the green band here, is the function that we want to optimize. And then we find the best combination of the controller parameters, some x optimum, a vector, let us suppose, so that this function is optimized. Of course, we do not have access to the function, right? So we cannot measure it, and it's very expensive. So there are several derivative-free optimization methods in the literature. We decided to use Bayesian optimization. So the principle is simple. We want to fit a surrogate function to the samples of this f of x. So I know if I run simulations how good or bad is my control design. So I fit this surrogate function to the samples of f of x. And I also minimize an acquisition function, which is going to tell me what to sample next. It's going to tell me what is going to be the next point in an exploration versus exploitation framework. Now, let's see how Bayesian optimization works in a general function. So the f of x in this case is expressed by the following line on top. And here you see the visualization of the f of x for various parameter values. We want to get to this point, right? So we want to maximize this function. And we start with the red samples that you see there. See if that works. No. It's an animation. Huh. Can I get it from here? Yeah, so you see, with the Bayesian optimization, I generate more samples until I get to my optimal point, okay? Let's see the next one. Okay, so this is another function, and again, I want to optimize those two parameters so that I get to the minimum, which is the point here at the bottom in this case. So I let it run again, and you see, as I am drawing samples, thanks to my acquisition functions, I get to the very bottom, which is the optimal point. Now, how does this relate to our glucose problem? Well, what if I can, no, okay, yes, it's going. What if I can get an f of x function that has a shape, not necessarily like the two that I showed you that were kind of nasty to find the maximum and the minimum, but something like this one. So this is the time in range generated for two representative patients that we have in a simulator in a in silico population. So given some initial samples in the dots, we generate our particles, which are the diamonds, and we are interested in maximizing the percent time in range, okay? So the shapes of this function are much smoother in this case, and we expect that we can find the optimal in a much easier way. Now, once we have found the parameters R and Q that optimize our metric in this case, we plug them back into the purple, well, actually it was magenta, cost function that I showed you at the beginning, so that we can apply the DEMU SPC, our controller, and we can generate simulation to see if it works. So here I show you just two representative patients. So on the left, we have the glucose concentration in milligrams per deciliters on the y-axis and the time in minutes on the x-axis. So the acceptable range is in the dashed green, so the 70 to 180 milligrams per deciliter. And we compared the Bayesian optimization tuned controller, the one leading to the blue curve, with some manual tuning, which is the dashed. So we have one controller for the whole population that we tuned by hand at the beginning of the exercise. And on the right, you see the insulin being injected. Again, the personalized version versus the population-wise. So you can see how Bayesian optimization allows us to get into the target range more smoothly than the one-size-fits-all controller. What about the second one? Similar thing, again, milligrams per deciliters on the Y and time in minutes on the X. And here you have picomole per liter insulin delivery. You see the difference between the general controller compared to the individual specific one. Again, this is all simulation and not real data. So what can we conclude? Well, I've shown you how we can use what we call data-enabled predictive control, an optimal control strategy, to compute optimal insulin doses for patients and automated insulin delivery. And how we can use Bayesian optimization with Gaussian process, surrogate function, and expected improvement acquisition function to obtain individual-specific parameters that we feed back into our controller. So we have done in silico clinical trials with a population of 10 patients using our simulator, and so far the results show the superiority of this patient-specific data-driven tuning compared to the population-wise one-size-fits-all controller. However, one aspect that we haven't considered yet, and it's very critical, especially in the case of diabetes, is the safety of the mechanism. So we haven't encoded any safety in our Bayesian optimization, and we will consider it next. So this concludes my presentation, and I'm happy to take questions. There you go.
Thank you. Questions? I see a hand up there.
Thank you for that talk. So I guess my question is, in these closed loop systems, you've got one sensor input, right? And you've optimized that now, like you've shown. What happens if you add more sensor inputs? What happens with another wearable that measures blood pressure and heart rate and, you know, activity, these other things that, I mean, commercially available sensors can do now?
Yes,
can you apply this to that as well?
Yes. So what will be different will be the prediction model here. So for now, here I just have one measurement from the sensor, right? This is just that sensor. Suppose we have an activity monitor that is giving me information about the physical activity. Well, I can encode it maybe somewhere as an input, and that is going to tell me how glucose is going to fluctuate in response to that input. So this is one way of doing it, and the other way of doing it is in the loop. No, not this one. Well, yeah, we can also do this one. So I showed you how I can have a different sensing mechanism. In fact, here is a wearable. I can have it in the decision algorithm, but I can also have it describing the disturbance. And we have done some work on this, just that we are not there yet to incorporate it in a closed loop. But yes.